gout drugs, the 7 gout drugs we need to know: acute 3, chronic 4, and then I want to speak about TNF alpha inhibitors, which are really good for anti-inflammatory drugs, which drugs can prevent the inflammation. So that's going to be your rheumatoid psoriatic arthritis, involves extensive surfaces of our elbows and the wrist. So first of all, we're going to start with chronic drugs. I want to highlight 4 drugs for you guys that are going to be used in the chronic. Okay, allopurinol, febuxostat, more or less the same drug. Then we have rasburicase. Rasburicase can be used in a chronic. So plicoticase, rasburicase, same thing. And we're going to use probenecid. Okay, so allopurinol are competitive inhibitors or xanthine oxidase. All right. So competitive inhibitor is when a substance like allopurinol inhibits a substrate, so xanthine, binds to the active site of the enzyme. So competitive inhibitor of xanthine oxidase decreases the conversion of hypoxanthine to xanthine to urate. As we can see over here, purines, hypoxanthine, xanthine, and then becomes the plasma uric acid, goes to the kidneys, and from the kidneys it can go into the urine, or we can get tubular reabsorption. So what drugs prevent tubular reabsorption are thiazides and low dose salicylics. So we should be very careful with when we use these drugs with gout patients. And then which drugs prevent the reabsorption? That's going to be our probenecid, which we're going to, and high dose salicylates, which we're going to be speaking about in a good amount of detail coming soon. All right, guys. So allopurinol is going to be essentially to make competitive inhibitor xanthine oxidase, decrease the conversion of hypoxanthine into xanthine to urate. Also used in lymphoma, leukemia to prevent tumor lysis syndrome, and it's going to be preventing the urine nephropathy. Increased concentrate of xanthine oxidase active metabolites, so azathioprine, 6 micropyrin. What does that mean? I have a link over here. I'm going to speak about that. So azathioprine can be converted to 6 micropyrin. I don't know how. It's not too important. And essentially, this drug is going to be metabolized by xanthine oxidase. So when we give this allopurinol, it will increase your 6 micropyrin. So when we give 6 micropyrin and we give allopurinol, we have to be very, very careful because it can maybe cause some toxicity. Coming back over here, plicoticase. Plicoticase is same as rasburicase. They both have the K's in it. They basically are gonna be urate oxidase. So they increase an enzyme called urate oxidase, which they are a recombinant uricase, which converts uric acid into allantoin, which is like water soluble. It can be excreted from the body. So uric acid into, so uricase is going to be the main drug that this is going to be basically. Febuxostat is the same as xanthine oxidase, and for probenecid, it prevents reabsorption. So it's going to be the proximal convolution inhibits it also inhibits the secretion of penicillin and can preserve uric acid, calculi, and some other drugs. All right. So then we're going to come over here to these drugs, which are the acute gout drugs, and we can also use these for pericarditis. Okay. So we have NSAIDs. We spoke about NSAIDs in my previous MSK video. So that can be indomethacin, ibuprofen, naproxen, diclofenac, ketorolac, and they will reversibly inhibit cyclooxygenase 1 and cyclooxygenase 2, which will prevent you from making fine compounds, thromboxane A2, PGI2, which is basically a vasodilator. Then we have the prostaglandin E1, which is also a vasodilator. Then we have the PGE2 and F2, which are basically uterine contractions. Nothing too different over here. So essentially, what happens is that we are going to be getting the over here. We're going to be any NSAID, so we're going to be having the salicylates with caution because they can decrease uric acid secretion, particularly low dose. So we be cautious. Glucocorticoids, we can give them oral, intra-artically, and parenterally. Colchicine, they basically are going to be stabilized tubulin to inhibit microtubulized polymerization and impairing neutrophil chemotaxis and T-granulation. And the acute prophylactic value, GI, neuropathic, myopathic adverse effects, can also have myelosuppression and nephrotoxicity effects as well. Let's come into TNF alpha inhibitor. These are nothing to do with gout, by the way. These are like completely different. These are basically going to be there for inflammation. So we're going to be using them for rheumatoid arthritis, which is basically all attack to our joints. Psoriatic arthritis, also a joint, but also our skin. And maybe some ankylosing spondylitis, which is also attack to our joints. And we can also have this for ankylosing IBD. So etanercept is basically it's a two things. So it's an FC portion. So I'll mention FC portion. FC portion of the IgG, and then we have a TNF alpha receptor on top. Okay, so like it's like a two thing. Okay, TNF alpha decoy receptor. So it's like a decoy. It's like a distractor. Like kind of like how if you were to like kind of throw a bone at a dog, the dog get distracted. So TNF etanercept is basically like it's like you throw a bone at a dog. It's a decoy receptor, and basically we use this for many cases. And this is the one I want to speak about: infliximab, adalimumab, golimumab. Infliximab and adalimumab are high yield ones. Okay, these are monoclonal TNF alpha monoclonal antibodies. This, guys, is going to predispose to reactivation of latent TB. Since TNF is important in granuloma formation and stabilization, can also lead to drug-induced lupus. So as we know, I'll have a photo over here. So when tuberculosis comes in our body, what happens? It goes to macrophages and then T helper cells. Okay, macrophages, the two big boys here, T helper cells. Okay, this over here, TNF alpha is going to be stimulating interferon gamma to make granulomas and like kind of protect the body. Over here, we're going to be getting TNF alpha. So TNF alpha is then going to help to make even more like cells and come and kill. Okay, so that's going to be over here. Of course, if you don't have this TNF alpha, you're not going to get cells. So you're going to get more predisposition. I've also seen an NBME, I believe number 11 for step 2 CK, where they said that you should check cells. So apparently TNF alpha has some, it can bring down cells. Imiquota, not too important, but we can use anal genital warts, actinic keratosis. It basically binds some toll-like receptor and it can modulate, but it's not high yield for USMLE. Okay, guys, I'm going to make it very simple. Allopurinol for boxers inhibit xanthine oxidase. Pegloticase is a uricase. It's a uricase, converts uric acid into allantoin. Probenecid prevents reabsorption. NSAIDs, glucocorticoid and colchicine are very important for acute gout. And TNF alpha, such as etanercept, is going to be a decoy receptor with the FC portion. Infliximab are going to be monoclonal bounties against TNF alpha. So guys, this was the gout drugs. Hope you found this video useful, and I hope to see you guys next time.